Right, so for those of you who are still sitting in here, this is the partnership session. How can collaboration across different sectors drive investment in research and bring benefits to patients? So for those of you who don't know me, my name is Carys Thomas. I'm Head of R&D Policy in the Health and Social Care Group in Welsh Government. Absolutely delighted to be chairing this panel and parallel session today, and we've got an excellent group of speakers which we're going to hear from very shortly. Just to kick off, as you'll probably gather, collaborative working in its various forms is the glue that draws together much of what everyone is doing. And really sometimes only by stopping and reflecting on its importance, we actually almost remember how much of it we do in our working lives, but in our personal lives as well. So as the phrase goes, no one is an island, no one person, no one organisation is an island. We won't succeed if we work in isolation. And we need to work as part of a community in order to succeed and thrive. So what we have about to kick off is a series of very short presentations from our speakers who are going to share their experiences of how they've established meaningful partnerships and collaborations, and what was their impact and benefit, and possibly some of the challenges that come along with that. So to kick off, I'm going to hand over to Leighton Phillips, Director of Research and Innovation and Value at Hywel University Health Board.
I always think you should leave the applause until you've heard what I've got to say. It may be absolutely awful, but thanks for the introduction, Carys. It's a pleasure to speak to you today, and it's caused me, I guess, to reflect a little bit on the word collaboration, first of all. We use it frequently, collaboration, partnership, I guess partnership being a longer-term form of collaboration. The first thing that I'd like to start with is just to say I couldn't do my job without collaborating with other organisations. I couldn't be a Director of Research, Innovation and Value. And one of the reasons for that is, of course, with the kind of challenges that health and care are facing these days, whether it's children's mental health, respiratory disease, Jamie, I saw you second row back, cardiovascular disease. The nature of the problem is rapidly evolving, and therefore the solutions need to rapidly evolve. And take any one of the conditions that I've just mentioned, the solutions reside across organisations. So, and that includes research. So how do we do meaningful research without collaborating? Collaboration is also the opposite to transacting, I guess. Transaction means that I've got a firm understanding of the problem and a kind of solution that might respond to that problem. And I don't believe that's to be the case. Health challenges evolve, care challenges evolve. So collaboration is not optional. I think it's absolutely essential. So I thought I'd just reflect briefly, before the red flag emerges, on the ingredients of successful collaboration that I've seen from managing a portfolio of innovation and research. Confession, I know this is a research conference. This isn't based on evidence. This is just based on the experience of managing collaborations, and some have gone horribly wrong. Some have gone right. So the first ingredient is having a clear and common-ish purpose. I choose common-ish deliberately. Maybe aligned purpose is better, because every organisation and individual will approach a collaboration differently. For some, profit may be the primary driver. For others, affecting a health condition will be a primary driver. For others, personal progression may be a driver. And I'm okay with that. I think it's important to recognise that people enter a collaboration for different reasons, but it's important that there's something common that unites everyone, otherwise it will fail. My next ingredient, 3 ingredients, I'm being sneaky with my 4 ingredients here, is the balance between resources, reward and risk. So for a collaboration to be such, to be a genuine collaboration, I think there needs to be a willingness to pool resources. Resources aren't always financial. They can be time, they can be people, dedicating time, but also having an understanding of where the reward may come from the collaboration, and a preparedness to also accept risk and share risk and acknowledge that sometimes the collaboration will not deliver what was intended or hoped for. The third is the one that I feel most passionately about, and it's relationships. I think, Carys, you just used the word glue. I think that the relationship is the glue that holds the collaboration together. And just to go back to the word transaction, if I transact for a solution or product, then I probably contract. Contracts can only take you so far. The relationships between collaborating partners ultimately what I feel creates a success, and when things start to go wrong, it gets us back on track. And then finally, final ingredient, at least from me, is credibility. And I think credibility can be assessed by looking at the balance of resources, testing the relationship, whether it feels right, and also, of course, testing whether there's common purpose. But credibility is something that is kind of an instinctive judgment, I feel, as well, that I can tell you that I had early signs of the collaborations that went wrong even before we'd entered contracting. Something still drove me to doing that collaboration, but my instinct was telling me that this possibly isn't going to work, and maybe that's something we can discuss. So I'm happy to give examples in the discussion that follows. Interestingly, and you're going to think I've gone completely mad when I use this as an example, driving down to the venue this morning, I was listening to Radio 4, and superglue was the subject of discussion this morning, and the medicinal use of compounds that go off quickly, i.e. superglue. And you're thinking, well, what the hell does this have to do, got 1 minute to go, with collaboration? Well, superglue started within the military application. It was actually, and I've learned this morning, this is definitely not based on years of credible research, but it was based on trying to find a quick fix to visors and glasses breaking in military combat. And there were problems in developing that technology, and the person who was driving it then moved into aviation. Again, fixing the plastic on the visors within aircraft. And what they found is that in the factory, when people were using superglue, their fingers started to stick together. It was starting to become a bit of a problem, and the military medicine then got interested in that, but the compound was going off too quickly, so when they were spraying it on wounds, it was like creating balls of water. So then the research kicked in to evolve. Now, no one started thinking about superglue, a fast-acting glue for medicinal application. Actually, it was born out of a completely different industry sector. There was just a sparky innovator, researcher, who ultimately thought it didn't work within the one application, worked in the second application. It had an unintended consequence in terms of sticking people's fingers together. Probably not a consequence you want, working within the factory. But ultimately, then that evolved into something that has saved countless numbers of lives, both in combat, but of course also within healthcare systems. That is my take on collaboration. Thank you for listening.
Right, so both Leighton and I are talking about glue. So I think the task for the rest of the panel is to integrate the word glue into your talk. So next up is Louise Davies, Director of Public Health, Protection and Community Services in Rhondda, Cynon, County Borough Council.
Morning. Thank you for the opportunity to come and speak to you today. As Carys has introduced me, I'm one of the directors at Rhondda, County Borough Council, but I'm also the co-director of the Rhondda, Health Determinants Research Collaboration, or the RCT-HDRC. So my role today is to share a local government perspective on the opportunities and challenges that our innovative collaboration is already facing. So in terms of background, in 2022, NIHR launched the HDRC programme, offering investment of £5 million over 5 years to local authorities to enable them to become research active. The opportunity aims to boost partnerships between local government and the academic sector, enabling councils to make better evidence-informed decisions. HDRC also aimed to develop a culture of co-production with citizens and involve them in shaping and undertaking research to focus on what works and what matters in respect of the wider determinants of health. So the funding is not, therefore, to undertake research, but to create the culture that will enable research to happen. 13 local authorities across the UK were successful in the first tranche in 2022. And in 2023, RCT Council worked with the Wales Centre for Public Policy and Cardiff University as our academic leads, and our collaboration partners in Cwmtawd Morgannwg Health Board, Interlink RCT as our Community Voluntary Council, and Public Health Wales to secure full funding for our HDRC from January this year. While this session is looking at how collaboration can achieve benefits for patients, our collaboration is about early intervention and prevention. And while local government services impact on many of the wider determinants of health, we don't have an embedded approach to research activity. Neither do we have, as we are fast learning, a clear way of accessing the system that supports such activity to unlock the opportunities that we need. There are only 30 HDRC in place across the UK. However, the potential benefits these can bring to the culture of research collaborations in Wales and the UK are significant. So what is our HDRC? Firstly, it's a collaboration of partner organisations that would not normally work together, and that's important. It's underpinned by formal agreements, and obviously, as we've already heard, they're not the most important thing, but they do bind the partners together to deliver a specific programme of work packages that we've committed to. It's very much a response to population need. RCT is a unitary local authority, and 27% of our citizens live in the most deprived areas of Wales. Our average overall life expectancy is lower than the Wales average, and we also have more children living in poverty and a higher proportion of overweight and obese adults. It is, however, an opportunity to deliver on council priorities, to build on our strengths in RCT and use collaboration to develop an infrastructure, particularly to increase internal capacity to undertake research and improve mechanisms to support active citizen involvement, as well as using existing data to understand needs, outcomes and impact. Importantly, it's about an opportunity to add value, and that's a key part of a successful collaboration. HDRC will use the expertise of our collaboration partners to advance the Council's ambitions, but also to benefit partners by offering a local government perspective to research activity. It's not just about direct financial investment, which was important in securing that from NHR. It also brings about significant benefit in kind, both for local government, while enabling the expertise of our council, our citizens and our voluntary sector to influence those more traditional academic and health domains. So what have we learnt so far about what will make the HDRC an effective partnership? So it is early days. Obviously, the funding was only in place from January, and it is still a very exciting opportunity for all of us that are involved. And the formal mechanisms, as I said, are already important, like a partnership agreement, and obviously the funding to create a resource capacity needed. But our partnership is based on strong relationships and a collective ambition to create that capacity for change. We have had fantastic commitment from our partners from the outset in developing the bid and since securing the funding. We do have a shared vision. It's underpinned by an evidence-informed model of how to effect change, and our approach is, however, pragmatic to ensure what works in theory can and should land well in local government. We are learning there are significant cultural differences between organisations and structural system differences across the UK. We don't have a common language. We each have complex governance arrangements that affect how decisions are made, particularly in democratically accountable local authorities. Understanding our differences is, however, invaluable to a collaboration if we're to identify realistic outputs and outcomes. While the HDRC is about changing the culture of local government, we are using the collaboration to explore changes within our partners to ensure it's not just a one-way process. Drawing different organisations together is exciting, but one that does have to be supported and managed respectfully. If we are to bring about cultural change, we believe the HDRC has to have the council at its heart and connect with existing council processes and not become something that is done to our council and to our citizens, but with us. We are showing innovation in a way that hasn't been accessible previously, and we are learning practical realities of turning research into new practice on the front line. And we're testing the boundaries of organisations and very much already learning on the job, particularly about things like ethical approvals, who knew, eh? Maximising the use of existing partner infrastructure, of course, as we learn. So realising the vision of public involvement has begun in earnest. It is at the heart of our HDRC, and perseverance to develop that relationship will be key. We are being challenged continually by our voluntary sector partner to avoid tokenistic activities and genuinely deliver co-production. However, if we are to maintain cross-pollination between organisations as part of these collaborations, we are learning that we need to plan career pathways and development opportunities to maintain the relationship between local government, health and academia. We have to create an environment within the collaboration for staff to work across organisations if we are to sustain future progress. Finally, navigating how to use the experience of both the RCT HDRC to benefit regional and Wales system partners, as well as the wider UK network, is a critical action. Measuring success is essential to NIHR, and the 30 HDRC are working hard to share experience and learning to maximise the opportunity for every council, not just those that have been funded to date. I believe we all have a vested interest in defining what we mean by research-active local authorities so that we as a system can support that into the future. Thank you.
Thank you, Louise. And, you know, the achievement of bringing in a HDRC centre into Wales has been an enormous endeavour, and it's quite a new experience for you. So thank you so much for sharing your learning. Right, so up next is Professor Liam Gray, Professor of Functional Neurosurgery and Director of our very own Health and Care Research Wales Brain Unit, which stands for Brain Repair and Intracranial Neurotherapeutics. Thanks, Liam.
Thanks, Carys. Thanks, Carys. I hope you can hear me. I feel like something out of the Borg, tied up with all this kind of gear at the moment. So the topic that Carys has asked us to talk about is collaboration. And collaboration is what attracted me to Wales. As you would have gathered by my accent, I'm from extreme West Wales, and I do rather love the Welsh because I look at you as the Irish who couldn't swim. So I came here just over nearly 12 years ago, and the area that I really wanted to, I was attracted to the expertise that was in Cardiff for looking at advanced therapies for brain disease. So a lot of brain diseases are incurable. There's a huge social and economic burden, and there's a huge unmet need. And these new cell and gene therapies that are being developed hold really fantastic promise. But the problem with the brain is it's difficult to get stuff into it. And therefore, you have to deliver a lot of these therapeutics directly. And as you will know from Carys' introduction, I'm a neurosurgeon. And what attracted me to come in here was the potential to collaborate with people to take these advanced therapies forward and really get them into clinical practice and through clinical trials. And we set up the Health and Care Research funded Brain Unit back when I came here. Here we go. Back in 2015. And really that was to set up a clinical research facility at the hospital in order to perform these kind of high-end clinical trials, to collaborate with the people at the university and develop more of these advanced therapies, to work with the NHS and integrate what we were doing with clinical care in delivering therapeutics directly to the brain. And working with Anne Rosser and others, we were very fortunate in being one of the first places in the world to do the Ionis and then later Roche trial for an RNA therapy for Huntington's disease, and later for our own cell-based therapy called Trident. And at the moment, we're one of 4 or 5 places in the world doing the Unicure trial where we're administering advanced gene therapies directly to the human brain. And with the funding we've had from Health and Care Research Wales, excuse me, then we're doing another trial in frontotemporal dementia next year, and also a large trial in Parkinson's disease. And all of these trials involve putting the patient asleep in an MRI scanner, putting that little bit of plastic on top of their heads there, which is a very fancy stereotactic frame, putting very fine catheters into the brain, and slowly and deliberately and very focally delivering these very advanced therapies. And the reason we do it in an MRI scanner, as you can see here, there's 2 catheters in this patient's brain, and over time, this white substance, which is just a marker of the gene therapy that we're delivering, is being slowly advanced into the target structure. These operations take anywhere between 12 and 18 hours, so it's a long time and a lot of work. This is one of our patients who is having his frame put on. He's sound asleep under anaesthetic within the MRI scanner. And this is the scanner up at the Heath Hospital, where we actually do all this work. So the patient's head is fixed on the frame at the top of the bed there. The anaesthetic equipment is all on the left-hand side. The surgery is all done at the back of the scanner using MRI-compatible kit. And the infusion pump is a little yoke over there, like a television screen on the extreme right-hand side. And getting this integration of what we're trying to do into NHS practice has been a challenge. It's all very fine having the great idea, but getting people to work with you, competing with clinical care, waiting list initiatives, etc., has been a challenge. And we've learned a lot on how to collaborate with the NHS through the trials that we've done. However, we are a research organisation, and what we're trying to do is make things better. So here you're seeing, well, the light is a bit bright, but there you could see 2 target structures, which are the caudate and putamen of the human brain, and over time they're rotating around, and there's an increasing yellow blob and a blue blob. And the yellow blob is the therapy being administered to a patient, so we're tracking its delivery over time, and the blue blob is some escape of the therapy along the catheter back into the tract. Heretofore, this kind of level of analysis was not available. This allows us to digitize and measure very precisely the quality, the quantity, the rate of delivery for these gene therapies, which is really important because to deliver this trial for 40 patients is costing Unicure $1 billion. Each therapy is over 4 million. So they don't want me wasting any of it, and they want to make sure that it actually works. Because we can quantify this, we can now look at each individual patient, and Dr. Price this morning talked about databases. What he was actually saying as well is data, the value of having digital data and being able to measure absolutely everything. So we can measure in very fine granular detail how each therapy is being delivered in each individual patient, and then correlate that with how they're going to do. Because these are neurodegenerative diseases, so we know an impact by how they do over time. They stop getting worse. It takes time. We want to make sure we know that the therapy is going in so that it has been delivered. So if the clinical trial doesn't work, we know it's due to the therapy and not to bad delivery. And we don't want to have the situation where we've got a wonderful therapy, but because of poor delivery, the patients don't get a benefit, and therefore we've a missed opportunity. Okay? We're also doing some lovely work with Kubrick and Cardiff University. This is Dimitri and Sanchita, who are 2 of our trainees, looking at trajectory planning. Normally it takes me about 2 or 3 hours, and some of the other neurosurgeons, we all sit together in a big conference, and about over an hour or 2, we deliberate and fine-tune the tracks for each individual patient. This is a computer program that does it in 3 seconds. Okay? So this is a bit of innovative research that we are going to bring to the field to optimize it for each individual patient. From the point of view of developing ATMPs, we're collaborating with the universities. So working with people like Anne Rosser on Huntington's, Alan Parker on brain tumours, and Vincent Dion on CAG repeat diseases, using human tissue, and also developing up new gene therapies and new cell therapies for these diseases. To improve delivery, we're working with scientists at Kubrick, so Derek Jones and his team, and also Sam Evans in engineering to design better devices. The devices we have are okay, they work kind of, but they could be a lot better. And this all comes together within the clinical trials that we run, and with Cheney Drew from the Centre for Trials Research. So this is the whole crew, really, that are doing the innovative and scientific end of what we're trying to do in our research. And what's the opportunity? Where are we going to go with this type of work? Well, we want to develop a clinical research industry centre of excellence so that we can really move the field forward and be a centre of excellence that attracts research, attracts industry, and also gives our patients in the UK, some of our patients are from England, some from Scotland, and some from Wales, and give our patients a first crack at these advanced therapies and the benefits that accrue from them. So what are the barriers and opportunities? We know from the O'Shaughnessy's report that it is not trivial to do these kind of research trials within the NHS. There are many, many barriers. And really, to summarize, we need to work with, and we need dedicated infrastructure and staff for doing these type of trials within the NHS. So we need the kit, we need the theatre staff, we need the research nurses and the ancillary staff, and we need the clinical research facilities to do this kind of work in. And this is a picture of one of the participants we did in one of our trials. He's given permission for this, he's sound asleep, and you can see the surgical team around all folding their arms. Not because we're not doing anything, we're having a WHO timeout, checking and double checking and triple checking that absolutely everything is absolutely spot on from a safety point of view for this patient. So your clinical trial facility is great for organising your research, for doing all your regulation. But when you come into the NHS, it's safety that is the key issue. We've got to keep our patients safe. And a lot of the work we've done with the NHS and collaborating with them has been on maintaining the safety. Okay? And ultimately, we want to develop a partnership between the NHS, the research organisations, the pharmaceutical and device industries to really make ourselves a centre of excellence and move the whole field forward. And we have that ambition. And hopefully, we're going to be refunded shortly as the Advanced Neurotherapy Centre for the next tranche of funding for the next 5 years. We're not just working in Wales. We collaborate with a group of people around the world. These are the centres, the main people in the 5 or 6 centres around the world that are doing these trials, and they're spread across North America and Europe, and one or two and one in Asia as well. So our collaboration is very, very much international, and it's been led from Cardiff. So I'm sure we'll talk. Carys asked me to talk about glue. Sometimes I feel I am walking in super glue, trying to get things done within the NHS, but we are making fabulous progress, and I look forward to discussing it all with you. Thank you.
Thank you, Liam. Really fascinating and amazing stuff and developments going on there. And if there's anyone in the audience with some spare cash rattling around, then I think Liam will definitely want to be collaborating with you. Right, so I'm now going to introduce Dr. Paul Hywel, Programme Manager, Acting Head of Research at Imophoron. So come up, Paul, when you're ready.
Good morning, everybody. It's a pleasure to talk to you today. I've enjoyed hearing what we've heard so far from the contributors. I've got a more generalist point of view to bring to you today on my opinions on collaboration and what makes good collaborations. And I'm bringing to you an industry perspective. I work in biotech. I haven't always been in biotech. I've spent 18 years actually in life sciences, and most of that in Wales, and some of that in academia as well. So I've seen both sides of the fence and been involved in many collaborations, both between academia and industry versus academia and big pharma. So I've got some ideas of what worked well and what didn't. But I hope that you'll forgive me with a rather simplistic analogy. I'm not going to do a health and safety talk here, but this is the fire pyramid. Many of you have seen this before. And for those of you like me that have spent time with the expectant gaze of children waiting for a campfire to be put together so they can cook their marshmallows, or a hungry family waiting for those charcoal briquettes to take light when you're trying to cook a barbecue, you'll know the vagaries of the fire pyramid. But in this case, what I wanted to just highlight is some analogies that I've seen between this and good collaborations. So we know the fire pyramid consists of of the fuel, the heat, and the oxygen required to get the spark going, and the heat really is the catalyst there of the interaction between the two. But there is a fourth element which makes it the pyramid, and I spent probably a little bit too long with PowerPoint animating three-dimensional shapes to show you that it is a pyramid. But that fourth element, which is often forgotten, is the chain reaction. A spark is not enough. It needs to be sustainable. And so when I was thinking about how this relates to collaborations, keywords came to mind of collaboration itself, but sustainability, and then finally the outcome, which is the public and the patient output and benefit. So how does this relate then to good collaborations? Well, I'm going to propose to you a radical new pyramid, the collaboration pyramid. And the key thing is that I'd like you to consider whether you agree with the elements I'm going to equate to the fire pyramid. And if you don't agree, that's actually quite interesting. I'd like to know what you would put instead, whether you think this is too simplistic. But I think what this session is about is trying to draw those opinions. So for me, when I thought about this and tried to draw the analogy, I thought of the fuel as being the environment. So a good environment, which consists of the infrastructure that is provided, the funds that are provided, but most importantly, the people that are provided and are enabled in that collaboration are going to be the tangible parts of that collaboration to make it work, the fuel, if you like. And then I thought about what might be the oxygen. So in Wales, I'm proud to say that we do have excellence in science in abundance, and that excellence in a collaboration needs to be, in my opinion, not only in the practice of the particular tasks involved in that collaboration, but also in the innovation that got that idea going. Indeed, you've got to be working on the right project and start point in order to deliver that patient benefit as the outcome. But what's the catalyst that, or the glue, if you will, that brings that together? And I would like to propose that it's communication. And in my experience, communication has been really what makes a good collaboration succeed or fail. But most importantly, when we're talking about cross-party collaborations or cross-field collaborations, that communication needs to be multidisciplinary, it needs to be across boundaries, and it needs to be done in such a way that those different entities with different expertise can indeed understand one another. So that would be my proposal for the putative collaboration pyramid, and you may find that you don't agree with all of those elements, and I'd be interested to know in a discussion what you would put instead. But for me, the analogy of the fire is about the sustainability, because it is that fourth element that a spark is not enough. You need to have that sustained fire in order to benefit, to get the warmth, to cook the marshmallows, etc. And in collaboration, I think the final element that I would put in the middle is the impact. So reporting upon the success of those elements working together to deliver something useful for patient care is no good unless that's made apparent to those who fund the research and who will in future collaborate and participate in that research. So it's the communication, I think, of the impact that enables us to close the loop and facilitate the future successful collaborations and maintain the ones that we currently have. So in conclusion then, I think this is one way that you could look at what makes a good collaboration. As I say, I've been involved in a variety of them, and this is a rather generalist view, but I would be interested to have a conversation, and if there is sufficient time to do so, on what the opinions would be of that are. But just to finally put in a generic picture and generic quote, actually I did check the provenance of this one. This isn't just a random one that it turns out to be complete nonsense. Charles Darwin did actually say this, and he was highlighting the importance of adaptation, and clearly in collaboration there's a need to adjust and adapt to make it successful when you're working across boundaries. And I think when you do that, you do bring those pieces that everyone brings to the table together, and the final product will be the patient benefit, which I think is the remit of what we were hoping to establish as what makes a good collaboration deliver today. So I thank you for your attention and look forward to your comments. Thank you very much.
Thank you, Paul. Well, So the collaboration fire pyramid. So last but not least, Rachel Savery, Head of Programmes, Advanced Therapies Wales, is going to come up and speak.
Hello, everyone. For those who actually studied the agenda, I'm not Dallas Morgan, who was meant to be here, so I'm sorry if you've come to this session hoping that it might be her. I think she's poorly today. So I think I'm topping and tailing. So you've had Leighton introduce and talk about, when he listens on Radio 4 in the car, I listen to KISS and try to do the quiz that got quicker. So I'm here to say I'm the person in the room who isn't an academic. I'm not a medic by background, and actually my whole career has been formed really by partnership working and what that means and why I do it. And there's lots of people in this room who I've worked with through the years who sometimes ignore me and dip their heads, and other times they do say hello. So it's wonderful to be on a stage sort of talking about what actually I think I've made a career out of and actually been really inspired and enthused to do. So as Carys says, I'm Head of Programme for the Advanced Therapy Wales programme. That's the sister programme for, it sort of sits within the precision medicine portfolio alongside genomics. And we sit as a Welsh Government funded programme. But I'm also Deputy Director of the Advanced Therapy Treatment Centre Network, which is part of a UK initiative which brings together lots of UK centres that are focusing on delivery of advanced therapy clinical trials into the UK. So you can imagine I'm working with lots of different people, but also policy and direction, which I'm trying to follow. I'm trying to move forward as part of my role, but also what I genuinely believe we need to do as change makers within our roles and within the settings that we sit in. So the focus of that work is predominantly how we become the sum of our parts. So we're all bringing things into our system, we're all bringing the best of intentions, but actually how do we coalesce? How do we become better together to deliver against the challenges that we know we're facing? And in the NHS and in the broader sort of public sector, we're facing challenges that haven't been faced before. And so we've got to try and do things differently. And I suppose I'm your layperson here to say, you have the agency and you have the permission in your roles to be part of that change. If you think that it's the right thing to do, or you think that there is a collaboration that maybe our family or our friends would benefit, or the services that we see provided, that should be that fire that I suppose is in the middle of Paul's triangle. That's the fire, and that's what makes me get up every day and try and do something a bit different. And I always get told I've drunk too much coffee already, even though I do actually drink decaf. So the fire's burning constantly. But I think one of the lovely things about sitting on this panel is actually when the invite came in, I've worked really closely with 3 people on that already, and not just in recent years. So Paul and I worked together when we were in Cardiff Uni. Liam has badgered me for money successfully, so well done. And we're working together on his trials. And Carys and I have been working on and off together for some time. And I think it's those relationships which are the most important thing around partnerships and collaboration. And I've written lots of words, but I did write grease and glue. And that's how I've always described my job. Is yes, you stick people together and you try and hold on, even when it feels like it's not going to work. You persevere, you hold on to things, but at the same time, you're also providing things that make it just a little bit easier for people who are doing really hard jobs, really intense, roles within the NHS, the academic sector. What can you do to help facilitate things just to go a little bit more smoothly? And again, that's where I sort of see my role. So lots of the things I've ended up doing aren't necessarily what you'd class as being part of, I suppose, being in my lane. But that's sometimes actually driving the reasons why I am doing certain things. So I do genuinely think that when you're looking at this from, a very human perspective, we're all people who are trying really hard in difficult settings to achieve. What can we do together? There is nobody who's going to tell you no if you're trying to do something for the good of others and the system that you're trying to serve. We are publicly funded, and actually we should be enabled and allowed, within ourselves to feel like we can actually go and do things that maybe haven't been tried before. And it's okay to fail, because actually some of the relationships and the strengths that you learn about each other and the programs or the pieces of work are as valuable as potentially, delivering on successful partnerships or collaborations. So I can list a few, you know, but actually they started somewhere. And regardless of whether it was me or my team instigating it or others that I worked with, the most important thing that then happened was that somebody else got a fire in their belly. And so the most successful partnerships that I've been part of are the ones where other people actually understood, you know, they understood why we were doing it. They got the fire too, and then they started to believe and carry on in delivering it. So as we move in very transient systems, it really is for me about how do you get that shared goal. So I'm sort of paraphrasing a lot of what our panel have already said, but it's about feeling the passion, I think, behind this and really understanding why we're doing it. And I was going to do this, and I think I will, because I'm quite interested to know how people identify themselves, because I do really struggle in describing my job and what I do. And, you know, when you go to family meals or, like, your husband tries to introduce you and you're just like, oh, don't worry about it. I just work in the NHS. You know, that's my kind of don't worry, because it's so hard to describe. So I'm just going to ask you to put your hands up, because I want to know what you all identify as. And this is, so it's not binary either. So first off, do you think you're an academic? So if you put your hands up if you think you're an academic. Okay. Who then, also, so you can be more than one thing. So who works in a clinical setting? So who feels that they're on surface end delivery, they're either supporting AHP, so there's quite a few. And who's the rest? Who feel like you're facilitating that? So, see, there's more grease and glue in the room than you think and you realise. And actually what we need to do is join up all our expertise. We need to enable the people who are experts in their field to do things. And if it means sending an email that is a little bit out of your lane because you think it's the right thing to do, maybe we just go and do it. Maybe you go and make a phone call to somebody because actually you know they might be helpful one day or they might need something from you. You make it. And actually that is where I think we've got to go to. We're in a really difficult situation. The only way we're going to get ourselves out of this current climate is to work together in new and innovative ways. We work together properly and genuinely. And I think that we work in new and collaborative ways, in brave and bold ways. And if we fail, we don't have a go at each other. We pick each other up, we learn, and we move forward. So, sorry, that was me on my notes.
Right, thank you very much, Rachel.